watch inside to go deeper inside the flap itself. So here we'll put the watch itself. With this patient, the last one, or the last two patients, I used AC maintainer. It was my first time using the AC maintainer, and it changed a lot. It's keep the anterior chamber stable the whole time of surgery. Here we can see the filtration. We open the anterior chamber with 26 gauge needle. And this is the compass. It's coming with each packet. And here it's open. It's on the zero, the arrow, we can see it on the zero. So it's open. That's why we have drainage. So we will close it. And now it's 6. So it's closed. There is no filtration, or very few filtration. And now you connect, we connect the plate with the iWatch device. We have to secure very good the iWatch device itself, because it's not bulky, but it has to be stable. So that's why I'm putting the suture a little bit long to fix the iWatch. Just I'm making sure it's closed, and we remove and we have to cover the watch with the pericardium. This was my last patient, and this is my first patient. The difference with my first patient, I put viscoelastic with my first two patients. And actually I think so it was a mistake. I had low filtration. My first two patients, they failed. This is one of the challenges which I had with the first patient. We can just pass. So as I said, we are the 7th country. They send me certificate that I'm the 12th surgeon worldwide to put the iWatch. So we have 4 surgeons in UAE, 8 implants done. I did 5 of them. Here the adjustment, which is, I found it the most difficult part. The surgery itself, it's like any glaucoma drainage device surgery, especially the step of fixing the iWatch. And here was my first patient. This is first day post-op. His pressure was 27 because we closed the watch. There is no filtration. And just in the clinic, we use the pen now, the magnetic part, to turn it. And now it's open. It's on 3 because it's actually the opposite. 3 from both sides. So now it's open or half open, but the pressure went down to 3. So to close it again, I took like 30 minutes. I lost actually the sense where I put the watch itself. I thought before that it's a very bulky device, but honestly it's a very thin device. Next day you cannot even appreciate that you did the surgery for the patient. The watch itself, it's very small. So I wasn't sure where I put it. And here on the other side, there's one of my fellows. She was trying to check, to open the watch for other patients. So what's special about this device? Limitation of hypotony next day because we closed the system. No invasive adjustment. It's only with there's no suture like the Bervelt or the pole. It's only with magnetic. You can decide the intraocular pressure you want the patient to be on, and there is no corneal touch. No corneal touch because the nozzle itself is curved and rigid, so there is no lot of vibration. It's not moving a lot, so there is less of endothelial cell loss with this device. The plate, as I said, it's long, but it's less wide, so we have less chance to have diplopia, and you can control the pressure. So this is the special about it. Here we can see, I got this from the site of Rayon. Here we can see the most surgeon, they use the iWatch, and they show a study of 1,200 patients. After 5 years, they compared the iWatch with Ahmed valve, and they showed 0 hypotony with the iWatch, and 90% of success rate compared to 57% with Ahmed valve, plus 38 of complete success rate with the iWatch compared to Ahmed valve. It's promising. What's nice also here, the tube, as we said, the Ahmed valve and Burvelt, and it's curved with the iWatch. So we have less of endothelial cell loss. Those are my data. My first patient had severe fibrosis, and I explanted the iWatch from the first patient. I was so upset to do that. After 1 year, patient was on maximum medication again, but the pressure was 70. Second patient, 70 years old, primary upper angle glaucoma, advanced. Pressure was 45 before surgery, first month 14, then 27. Then I did for him diode. It was his single eye, so I did diode. He has poor vision both. I did diode for him. The pressure is 10 without medication, but because of the diode. And he has exposure of the watch after 1 month, so I switched again. The third patient, he's doing very well until now. His pressure was 27. All of them, they were on maximum medication. Pressure now 14, no medication, no complication. And then I decided to stop before doing number 4 and number 5. And I went to see Professor Mermoud in Lausanne. I was so happy to see him. Just to know more about this device. I felt that there is some science behind the device, which I don't know it yet. To adjust the watch was a little bit challenging. So I was honored to operate with him, and I visited also Rayon. I have no financial interest with this company, but I visited the company just to see the science behind it. And I'm so thankful to Professor Tariq Sha'rawi, Professor Leon Eo, because they used to accept my calls. I was complaining about what happened to me with my patient, my first patient. But now I have some tricks, which is maybe I have better result now with my last 2 patients. AC maintainer, deep scleral flap, open the watch as soon as possible if needed, not to be so late to open the watch. And I was so surprised that when I put my first, it wasn't planned, when I put my first watch, I received a certificate, and the hospital, my colleagues, they called me, my glaucoma surgeon colleagues, they called me, they told me, oh, you put the watch, okay, this is nice. And I received a lot of calls from the TV, the journals, my friends, and I became just famous because of the iWatch. And by the way, a lot of patients, they call me, want me to put the iWatch, but I give them a different proposal. I cannot give my real opinion now about the iWatch. I think I need to do at least 5 more patients, and will collect the data from my colleagues in UAE who did already the iWatch. So what's my experience? It's a very elegant device. I had this feeling that I'm putting Swiss Rolex in the eye of the patient. So it's really amazing to put the device itself, but you have to deal with all the complication later on. Thank you so much, and I'm inviting you to our national conference of the Emirates Society of Ophthalmology in February 2023. Thank you so much.
With this, we move on to the next speaker, Dr. Suresh Kumar Gupta. He is my colleague from India, and he would be talking about clinical outcome of Ahmed glaucoma valve and anterior chamber versus ciliary sulcus.
Respected chairpersons and friends, a very good evening to all. At the outset, I am grateful to Professor Al-Amri and Meom team for the invitation. And I'll be speaking on change of my clinical practice to sulcus implantation of tube in certain group of patients. Glaucoma drainage devices, they have become surgical modality of choice in high-risk glaucomas, and literature supports their ever-expanding indications, including their use as primary procedure even in primary glaucomas. As we all know that with the introduction of Molteno implant, he introduced a tube which has long tube with plate which was implanted around 10 millimeter from the limbus, and all subsequent implants, they are based on this design. An ideal GDD should be made of biological, inert and flexible material, and it should be easy to use, and it should have good control of intraocular pressure, and it should last for entire life of patient. Unfortunately, we don't have an ideal device, and the commercially available devices are valvular or non-valvular. So Ahmed glaucoma valve belongs to valvular devices, whereas Maltino, Berwald, and currently Orolab aqueous drainage implant available in India, which is based on Berwald implant design, they are non-valvular devices. So the landmark study, TVT study, basically showed that tubes are comparable to trabeculectomy with MMC in safety as well as efficacy. However, tubes are not panacea for everything. They have their own set of problems which are, different from trabeculectomy, like tube blockade, tube migration, extrusion of tube, then erosion of conjunctiva over the tube. You can have motility disturbances and corneal endothelial loss, which is gradual over years. You can have corneal decompensation, especially in patients with post-penetrating keratoplasty glaucoma. So in our department, we are using these devices for high-risk glaucomas routinely since more than a decade. And then we had a patient of aniridia in which AGV was implanted with tube in the anterior chamber. And after a few years, he reported with corneal edema. And we have a lot of post-penetrating keratoplasty glaucoma patients being referred from our cornea services. Again, in these patients, implanting tube in anterior chamber will increase the risk of corneal damage and decompensation over a period of time. So we went into literature, and this article published in Cornea 2015, effect of glaucoma tube shunt parameters on corneal endothelial cells in patient with Ahmed valve implants. This inspired us to change our clinical practice. It reported that the prevalence of corneal decompensation after GDD anterior chamber ranges from 1.5 to 21%. And they found that most important parameter is relation of tube or distance of tube from the endothelium. This was most important clinical parameter. And they advocated use of tube in the ciliary sulcus so as to keep it away from the endothelium and